How about moving on to the next question, hypokalemia. Here people, hypokalemia, that means potassium is less. What will happen? Some old notes we found. So basically serum potassium level is below what? 3.5 milliequivalent per liter. Okay, so there is hypokalemia. So look at this. Why is there hypokalemia? Because either there is loss is more, maybe they're taking diuretics, I feel, or they are having less potassium intake, or they have some transcellular shift. Obviously, intake is less or output is more, or transcellular shift is there. Okay, so these are the reasons for hypokalemia. They have written very, very generally. Okay, then vomiting is a cause of hypokalemia. Please pay attention here. Vomiting is a cause of hypokalemia. You will vomit out everything. You will vomit out everything. Even potassium is gone. Right, then, so this will result in what? Metabolic alkalosis. I want to write here, metabolic alkalosis. So vomiting is one of the cause. Now let us go here. Causes of hypokalemia. So basically there is loss, increased loss from your body. That is because of renal. You're taking some loop diuretics or thiazide diuretics. Say the names of these loop diuretics, furosemide, torsemide, etc. Right? Then they are also taking some other drugs they are telling here, or there could be acidosis of the renal tubules. Okay, cystic fibrosis, lot of syndromes they have mentioned here. Cushing syndrome, they can have hypokalemia, is it? Then diarrhea, vomiting, sweating also. Okay, please pay attention here. These are the first things you should try: diarrhea, vomiting, sweating. Then you now in decreased intake because of malnutrition, etc. And intracellular shift, that is in the treatment of DKA, diabetic ketoacidosis. Because of the treatment it can happen. Okay, so they're giving high insulin state. Remember, high insulin will lead to what? Hypokalemia. So remember, when you're treating any patient with diabetic ketoacidosis, etc., when you're giving insulin, you should be wary of this hypokalemia. So what will happen if there is less potassium? Potassium less. So let's write here. Potassium is less. So we have less potassium. So what will happen? No pot, no T. That's what we remember, right? So no potassium, no T. So T wave will not be there, or it will be suppressed, is it, in the ECG? Okay, so where are we? Okay, so what happens if there is hypokalemia? Look at this, okay? So, symptoms will be non-specific, okay? So you won't know what they are telling. That's what they say here. See, symptoms are non-specific and predominantly related to muscular or cardiac function. But if there is severe hypokalemia, so normal, what did they say, is 3.5, less than 3.5 milliequivalents per liter. However, if it is severe, that means if it is less than 2.5, then what will happen? There may be neck flop, abdominal distension, basically muscle weakness, they are saying. This ileus, so basically there will not be much of what am I saying? Some paralytic ileus or something, right? That's what we remember reading. Now, then what will happen? There will be cardiac arrhythmias. We told you, right? The heart, no pot, no T, that kind of situation. And if there is chronic hypokalemia, then there can be some renal disease which is associated, which you'll have to check. Okay. Hypokalemia increases the risk of digoxin toxicity. So if there is hypokalemia, if you are giving digoxin, right, it will increase the toxicity risk. So that's what you have to remember. So the treatment for this patient, basically you'll have to treat whether if it is associated with hypertension or acidosis or alkalosis. So it can be either of them. So you'll have to treat this. You'll have to check this hypertension also, why it is happening. You can know whether it is primary hyperaldosteronism, something to do with your aldosterone levels, right? Primary hyperaldosteronism, renal artery, some stenosis, okay, some stenosis of this renal artery. So what it's doing, because it is going to be having hypertension. Okay, pay attention here. Some adrenal hyperplasia something they're blaming here. Congenital adrenal hyperplasia. Then glucocorticoid remedial hypertension or Liddle's syndrome. Wow, these are all very, very high-fi terms. Okay. Then there can be some Barter or Gitelman syndrome. Okay, some tubular disorder. Tubular disorders. Here again there is paralysis. See, they are saying acute flaccid paralysis, they have written here. So basically here they again landed up explaining the cause of the problem and they are saying treat that. Okay. And then what they are saying here, how will you treat? Let's use a green for this. Wait. How will you treat? So basically you will, losses if they are there, you reduce the losses by stopping this diuretics, right? Or if you're giving alpha-2 agonists, you stop that. Then potassium, you give the person potassium. You replace the potassium stores by oral or intravenous administration of potassium chloride, right? And then if there is some specific disease, then you treat that, like Bartter and Gitelman syndrome. How will you treat that? By giving indomethacin angiotensin converting enzyme inhibitors, ACE inhibitors. Give an example of ACE inhibitor. So here you have here enalapril, right? Enalapril, etc. When they said you have to give them potassium chloride, how do you give? There are tablets here. A lot of multivitamins they are seeing here. Potassium chloride tablets. There's some electrolyte also they are seeing. There is some KCl injection, potassium deficiency. Did you ever see this injection being given? See, here itself they have written potassium chloride 15%. This is the, you will give IV infusion over 1 to 2 hours, okay? And how to give so much, it should not exceed, all this if you get, you'll get too many marks. Then you have oral supplementation. So you have injection, that is IV injection, then you have oral supplementation. And then stop and replace losses if it is happening, okay? So normal saline volume resuscitation they are seeing, okay? Correct hypomagnesemia. So basically underlying etiology you have to fix. Magnesemia, this hypomagnesemia, magnesium is Mg, right? Yeah. So basically in surgery textbook what they have given is normal potassium levels is 3.5 to 5.5. So if it is going beyond below 3.5, then it will become hypokalemia, right? And the causes is reduced intake, tissue redistribution, increased loss, renal causes, okay? So the symptoms will be anorexia, nausea, muscle weakness, paralytic ileus, and the cardiac, we told you, right? Reduced height of T-wave, etc. A lot of other things they are telling you. Then how will you manage? You will find the cause and treat, and you will also replenish these body stores. And then you can give milk, fruit juice, tender coconut water they are saying. Then syrup potassium chloride orally, and if patient cannot take orally or if you need to give IV, then you will give IV potassium chloride at the rate of this. And if there is any life-threatening arrhythmia, it should not, so you should not give it at a rate exceeding of this, okay? And you should keep monitoring ECG. That's all, okay. That is why as routine investigations, we always order serum electrolytes. Serum electrolytes will have 3 components in it. You'll have the sodium, and then you'll have the potassium, and then you'll have the chloride. What is this 4th one? We didn't see that in our hospital. Enough about hypokalemia. Let's go to